immune disorders or immune deficiency. Type. Primary immune disorders or primary immune deficiency refers to a big group of genetically based disorders. So by default, any known primary deficiency has an underlying gene defect, okay? At the moment, there's more than 450 known genetic mutations causing more than 450 known so far primary immune deficiency disorders. The problem with immune deficiency is that it's estimated that around 6 million people around the world have got some sort of primary immune deficiency. However, of all these 6 million people, only 10 to 30% are diagnosed. Yani, the main or most of primary immune deficiency patients are still undiagnosed or misdiagnosed or not diagnosed at all, okay, or underdiagnosed. Okay, in the past, we used to think that a patient with primary immune deficiency means that you're liable or susceptible to develop recurrent viral, bacterial, or parasitic infections. No, the concept of immune deficiency now has been changed because of الثورة اللي صارت بالdiagnostics خاصة whole genome sequencing or whole exome sequencing. So nowadays we know that primary immune deficiency does not only mean susceptibility to infections. It can also mean, number one, failure to get rid of the infections after they have already occurred, which means liability to develop chronic infections, either chronic bacterial, chronic mycobacterial, or viral infections, which means high incidence of morbidities, increased risk of morbidities, and organ damage. Second, immune deficiency doesn't always mean infections, okay? Under the umbrella of immune deficiency, there are other disorders like autoimmunity and auto-inflammatory processes in the body, okay? So it's no longer preferably called primary immune deficiency. Now we call it inborn error of immunity, that to indicate that it's not only a deficient branch or part of the immune system. It shouldn't be deficient, or it's not only deficient or not present or malfunctioning. It might be there, but sometimes it's maybe dysregulated or hyper-functioning, okay? So it's now called inborn error of immunity to indicate that there's some underlying error. It doesn't always mean a deficiency in one of the components of the immune system, all right? Nowadays, for example, we used to think that inflammatory bowel disease is a pure GI problem, right? Inflammatory bowel, like Crohn's and ulcerative colitis. Nowadays, because of improvement in diagnostic with genomic studies, we know that there's a sub-classification or another entity. We call it, for example, early onset inflammatory bowel disease. Early onset inflammatory bowel disease is a pure immune disorder. So it's a form of primary immune deficiency or inborn error of immunity. So a patient who presents with early onset inflammatory bowel disease needs to have an immune workup done. Okay? One important function of our immune system is recognition of self versus non-self antigens, right? So any error in the recognition of self and non-self antigen will lead to autoimmunity, meaning that our immune system is attacking our own cells, our own antigens, okay? So we divide our immune system into two major groups, the innate and the adaptive immune system, okay? The innate immune system is very important because it's the first fighter against any pathogen or any foreign antigen, okay? So it has to be there, it has to be ready all the time, and it has to act quickly, like in a matter of minutes or hours, okay? Because of how urgent we need to act quickly, it's not a very specific kind of reaction. Means that if you get exposed to several antigens, the reaction to those antigens would be the same, okay? There's no specific reaction produced for a specific antigen, which in another word mean that we have limited diversity and there's no pattern recognition receptors. إيش يعني pattern recognition receptors؟ يعني I recognize this antigen and I have a specific response to it, and our body is able to produce specific receptor that only bind to this antigen. Okay, so in the future, that means I have memory. So in the future, I should be able to recognize the antigen and act quickly. This is not the case in innate immunity. So it's rapid, quick, non-specific. There's no pattern recognition receptors, all right? And there's no memory. Example of cells in the innate immune system, neutrophils, macrophages, monocytes, complement system, physical barriers, and the immune reaction at the level of the mucosal membranes. In contrary, the adaptive immunity is the highly specific, it's the intelligent part of our immune system, meaning that it needs to recognize a specific antigen, it needs to recognize its pattern, and develop a specific receptor to that antigen, so that on subsequent exposure, only its specific receptor needs to bind with it, okay? It's like lock and key. It's the perfect match between the antigen and its receptor. And that perfect matching or interaction between the antigen and its receptor will produce a very specific, very organized immune response, stimulation and proliferation of specific cells of the immune system that can deal with that specific antigen, all right? This process needs time because you need to recognize, for example, you need to recognize this antigen, you need to present it through antigen presenting cells, it has to be opsonized by antibodies, and then in antibodies that has to opsonize this pathogen, they should have been already formed. معناته there's first exposure, معناته في B cell proliferation specific to that antigen, and B cells have formed a specific receptor on their surface just specific for that antigen. يعني مثلا هلا there's millions of viruses صح around us. So with regards to the adaptive immune system, there are million receptors. Each pathogen, each antigen has its own receptor that it has to interact with. Because of how sophisticated the reaction and how specific the reaction is, it needs time. So it needs days and sometimes weeks. Because of this delay, we definitely need that initial innate reaction. It's a kind of, let's see what we can do while the adaptive immune system is reacting to the antigen, okay? So it has memory, and as I said, it has pattern recognition receptors. The adaptive immune system, it has a very important role, is the differentiation between antigen versus non-self-antigen. So without the adaptive immune system, or if there is any glitch or any problem with the adaptive immune system, we will find what we call autoimmunity, self-attacking. So our immune system will attack its own cells and receptors. Don't forget about the local immune reaction produced locally. For example, when you get vaccinated in your deltoid muscle for the BCG vaccine, so initially you're exposed at that site of infection, of injection, right? You should have a local reaction. In case of the BCG vaccine, the main cells that need to react are T cells, all right? T cells are part of the adaptive immune system. So the adaptive immune system are B cells and T cells mainly, okay? So حكينا T cells هم adaptive, فمعناته they need time to properly and specifically react للمycobacterium antigen اللي بينعطى بالvaccine اللي هو live attenuated. So initially the innate system can do almost nothing. So the immune reaction that has to be produced after exposure to the BCG vaccine, it has to be through the T cell, which is, as I said, branch of the adaptive immune system. That's why, have you ever seen a local reaction to BCG or an abscess that forms within days? We never see that. So we usually counsel the family that after, for example, injecting a BCG vaccine, the reaction that we need to see usually appears after 2 weeks. Most of the time between 4 to 6 weeks after the injection. So this is just to clarify that how specific and how the mechanism of action of the adaptive immune system is different from that of the innate immune system. Now, with regard to that, the same vaccination process. So it started here in your deltoid. Does that mean you're immune just by exposure around the deltoid area? لا صح? So this local initial reaction, it's very important to produce systemic immune reaction to the BCG, صح, أو mycobacterium. How do we get exposed للمycobacterium? Tuberculosis, كيف transmission? Respiratory, صح? Okay, so through small respiratory droplets, right? So احنا the vaccine injected in the deltoid, but we need to have a ready to attack part of the immune system, the respiratory tract, okay? So this is to indicate how important the local reaction is to actually create a more systemic immune reaction somewhere else, okay? Another example is what we call the local reaction in the respiratory and the GI tract. So if you're outside inhaling like air, you're exposed to like hundreds of antigens, صح? Through your respiratory tract. You inhale a lot of particles. So you need as well to have a ready immune cells that can attack any antigen that could cause you a problem. For example, you need to have ready-made IgA, which are secretory immunoglobulins, ready in the respiratory and the GI tract to fight off antigen that we ingest or we inhale, okay? So the difference between the active and the passive immunity, so the active immunity, it's produced by your own body, so it's an active process of producing immunity. Your body does the job. With regard to the passive immunity, you give ready or ready-made antibodies, like when you give an immune-deficient patient infusions of IVIG or intravenous immunoglobulins, okay? Active immunity, زي ما حكينا, it's induced after vaccination or after exposure to pathogens. Passive immunity, it's either the transferring IgGs from the mother to their fetus through the placenta. So mothers give their fetuses ready to use IgGs or IgGs, or through زي ما حكينا given infusion of intravenous immunoglobulins. Because of how زي ما حكينا احنا active immunity, with an example about it اللي هي adaptive, it needs time, it's sophisticated, it needs stimulation, proliferation of specific cells. It tends to last longer, okay, because it produces stronger immune response than the one that you give ready to the patient. So if you give the patient immunoglobulins, they have a short half-life. Afterwards, they'll start gradually to fade away, okay? In active immunity, there's memory cells. Our adaptive immune system is responsible to produce memory cells. There is no such a thing in the passive immunity. In active immunity, it's good to give booster doses. لأنه with time, صح إنه it's prolonged kind of response, but with time you expect a response to start to weaken. So we give booster dose. For example, we give MMR in booster doses, صح? We give a booster dose of measles vaccine, صح? Because we need to potentiate our immune response to that specific antigen and keep the immune response at a steady state, okay? ما بدنا to slow down or to have our immune response fading away. In passive immunity, we don't need booster doses, okay? Active immunity, it's not useful in immune deficiency. ليش? Active immunity is not useful in immune deficient patient. ليش؟ لو we don't have immune cells capable of producing, for example, antibodies, right? Okay. We will now review quickly the most common groups of immune deficiency disorders or inborn error of immunity. We'll start with B cell disorders because they're much more common than T cell disorders. We'll start with X-linked gamma globulinemia, or what we call Bruton disease. Bruton disease caused by a genetic mutation in the BTK gene, which is responsible, which leads to abnormal or absent of B cell, إيش؟ B cell إيش؟ maturation. شو يعني B cell maturation؟ هلا ال B cells, where do they get produced? In the bone marrow, and then they have to what? Mature to turn into what? Plasma cells or antibody producing cells. This process of maturation, if it doesn't happen, that means our B cells are unable to produce antibodies. Okay, so the معناته المرضى اللي عندهم B cell disorder أو X-linked gamma globulinemia, they're unable to produce immunoglobulins. So if you measure immunoglobulin levels, almost all of the immunoglobulins will be severely or significantly decreased. Okay? What does this implicate? شو الأهمية بهذا الموضوع? Which infections? bacterial, enteroviral, parasitic infections. What we worry about the most هم البكتيريال infections اللي هم encapsulated bacteria. ليش؟ ليش احنا بنخاف من الانكابسوليت بكتيريا زي ستريبنوما، هيموفيلوس انفلونزا، نايسيريا؟ اوكي، لانهم encapsulated they have the ability to escape الphagocytosis، صح؟ So they need to be opsonized first. Opsonization it has to happen through antibodies. So the antibody will opsonize the pathogen and then it will be presented through an antigen presenting cell phagocytic cells in order to be engulfed and killed. Without this mechanism, we'll have real problems with encapsulated bacteria زي ما حكينا strep, Haemophilus and Neisseria, which are capable of causing pneumonia, septicemia, meningitis, recurrent sinopulmonary infection, otitis media, etc. Patient can be at risk to develop bronchiectasis or chronic lung disease because of the recurrent and frequent lung infections. Okay. And in specific, they are unable to produce secretory immunoglobulins. حكينا عنهم مهمين بالrespiratory والGI tracts. This will lead to increased susceptibility to GI infections زي بصير عندهم chronic GARDIS or GARDIA infection, okay? Or as some call it giardia. It's not only زي ما حكينا about susceptibility to infections. People with B-cell disorders or X-linked agammaglobulinemia, they have a 20% increased chance to develop autoimmunity or autoimmune disorders like SLE, for example, rheumatoid arthritis. They're also susceptible to develop autoimmune cytopenias. They're also susceptible to have malignancies as well. If you examine someone with proton or X-linked agammaglobulinemia, the most striking feature حتكون absent tonsils. هتفحصوا ما عندهم tonsillar tissue. ليش ما عندهم tonsils؟ لأنه 80% من التونسيلر كابسول أو tonsillar tissue هو B cells actually, okay? فإذا ما عندنا mature B cells ما رح يكون في رح يكون scanty lymphatic tissue بالtonsils فما رح نقدر نشوف tonsils أصلاً، تمام؟ لا, autoimmunity does not happen purely by antibodies. There's also other mechanisms like interactions between B cells, T cells, and major histocompatibility complex. So it's more complex than the level of antibodies. Yes, قصدك autoantibodies. There are other mechanisms to produce autoimmunity. As I say, there's cellular dysregulation, like T cell dysregulation. Okay, which is more serious, okay? Selective IgA deficiency. So it's the most common primary immunodeficiency disorder known so far. If you bring 500 people, one of them at least will have low level of IgA. Its clinical significance is somehow, so it doesn't produce significant clinical signs and symptoms. يعني most of those who have low IgA levels are totally okay, they're asymptomatic, okay? For those who are symptomatic, mainly their symptoms would be recurrent زي ما حكينا, respiratory and GI. لو حكينا ال IgA, it's a very important secretory immunoglobulin بالrespiratory tract وبالGI tract. So they will have chronic recurrent respiratory and GI manifestations or problems. People with selective IgA deficiency, they are at increased risk to develop allergies and atopy. Why do you think? ليش they have more risk to develop eczema, food allergies, atopies in general? So the absence of IgA means the loss of the barrier function, the GI. Barrier function معناته إيش رح يصير if you lose the barrier function? Increased permeability and decreased tolerance, immune tolerance. وبالتالي الامبالانس بالميكروبيوم أو الميكروبيوتا will lead to more susceptibility to allergies خاصة الاتوبي والfood allergies, okay? people with selective IgA deficiency, they have to be you have to make sure that you know, or if they get diagnosed, they have to be labeled إنه عندهم IgA deficiency. ليش؟ Excellent. So if they need blood, they have to receive washed packed RBCs. شو يعني washed RBCs؟ شو بنطلع؟ نعمل washing للبلازما بروتين، كل بروتين including immunoglobulins. لأنه إذا أعطيناه blood فيه IgA and they have deficiency بالIgA شو رح يصير؟ Our body will understand this is non-self antigen, so it start a reaction to it. فبصير عندهم anaphylaxis, deadly anaphylaxis, okay? Common variable immune deficiency من اسمها common variable. Common, it's not that common. Variable, يعني there are variable aspects of immune cells affected. Variable immune cells are affected. Severity is highly variable. Not all people or patients with common variable deficiency, they present with the same signs and symptoms. In literature, they say usually the presentation as common variable immune deficiency is in the second, third decade of life. But actually we can have hints much earlier during infancy, okay? So the natural history of those with common variable immune deficiency that during childhood, if they develop recurrent sinopulmonary infections, recurrent GI problems, while they are getting investigated for an underlying immune deficiency or for an approach to, for example, evaluate someone with failure to thrive, part of the immune workup is to do Ig levels, immunoglobulin levels. So they are accidentally found to have low immunoglobulins. This is what we call transient hypogammaglobulinemia of infancy. So it should be transient. They should be able to outgrow this. They should be able to produce more antibodies as they age, and things should be all right. A minority of those with transient hypogammaglobulinemia of infancy will continue to have abnormal immune reaction and low immunoglobulin levels, and then to be called as having common variable immune deficiency, okay? يعني most اللي بتشخصوا of common variable immune deficiency in their second to third decade, if you look back at their history, either their mom will tell you they used to have recurrent sinopulmonary respiratory infections, or that in the past they were diagnosed to have transient immune hypogammaglobulinemia of infancy, okay? As we said before, common variable immune deficiency, there are so many genetic mutations responsible of developing CVID. هيو موجودين عندكم. هلا المشكلة اللي بتصير those genetic mutation they're making the B cells unable to differentiate. So B cells with no differentiation شو رح يصير؟ B cell dysfunction. معناته again they will have a problem with producing antibodies to fight off bacterial, enteroviral, parasitic infection, and there will be a problem بالinteraction between the B cells with T cells, okay? هلا B cells with T cells, both of them, they have to talk to each other, تمام? They have to interact. For the B cells to stimulate the proliferation of T cells and stimulate specific type of T cells, they have to interact, and vice versa. For example, T helper T cells, they should interact with B cells to stimulate their proliferation, to encourage production of more B cell population or more antibodies. So they're both important to stimulate each other when we need them, when we need the adaptive immune system to be functioning properly and quickly, okay? So a problem with B cell differentiation will also lead to T cell problem. عشان هيك اسمها common variable immune deficiency, because it involves commonly B cells and T cells, both of them would be affected. زي ما حكينا, because there's no proper production of antibodies, معناته more risk of encapsulated bacteria زي اللي حكيناهم اللي هم الهيموفيلس, Neisseria, Strepnoma, معناته recurrent sinopulmonary infection, معناته risk to develop bronchiectasis or chronic lung disease. Because again of poor interaction between B cells with T cells, T cell the regulatory function is really important to prevent autoimmunity. معناته الناس عندهم common variable immune deficiency are liable to develop autoimmune disorders زي pancytopenia, autoimmune for example, hemolytic anemia, autoimmune thrombocytopenia as well. So a patient who's diagnosed with common variable, they have to be regularly seen and evaluated. At least you have to do CBC. بالإضافة that you have to pick out early signs of respiratory or sinopulmonary infections to treat them as soon as possible to try and prevent lung damage with recurrent infections. You also have to be vigilant and observe for the appearance of any signs of rheumatological problems, joint pain, joint swelling, abnormal skin rash, SLE manifestations, etc. Okay? They're also at increased risk to develop malignancies, like non-Hodgkin's lymphoma and gastric carcinomas. Now we'll move to T-cell disorders. T-cell disorders are much less common than B cells. It's a bit difficult to diagnose them. يعني احنا لما we want to diagnose B cells, we usually do immunoglobulin levels. لأنه the level of immunoglobulin production will automatically measure the level of B cell function, right? It's not the case with T cells, because T cell disorders doesn't always mean a qualitative problem. يعني you might find normal T cell count بالflow cytometry, but sometimes their function is abnormal, okay? Their regulatory function is abnormal, okay? طيب. The first example on T cell disorder is Dye-George syndrome. Dye-George syndrome happens when there is microdeletion in chromosome 22, leads to failure to develop the third or fourth pharyngeal pouch. هلا third, fourth pharyngeal pouch, they give rise to central صح midline defects. فبيكون في عندهم من الميدلاين defects بتأثر على الباراثايرويد على الثايميك gland. So we might see thymic aplasia يعني absence of thymic gland, or thymic hypoplasia يعني موجودة بس it's hypoplastic, or parathyroid aplasia, so absent of the parathyroid gland, or parathyroid hypoplasia يعني موجودة بس it's hypoplastic. They also tend to have other midline defects like cardiac, عندهم cardiac defects اللي هم truncus arteriosus will tetralogy of Fallot, okay? They, as well as part of the midline defect, they have abnormal facial features, coarse facial features as well. Some of them might have cleft palate as part of central or midline defect, okay? As I said, T-cell disorders هم شوي difficult to diagnose, so you need to have a high suspicion يعني عشان to look for T-cell disorders. So usually, people, for example, with Dye-George syndrome, we don't initially suspect an underlying immune problem. It's not why they get evaluated. They get evaluated لأنه, for example, issue be cardiac anomalies, chest X-ray was done, chest X-ray showed no thymic shadow or absent thymic shadow. So those with accidentally found to have absent thymic shadow, they need to be evaluated and followed up for the possibility of Dye-George syndrome. Scenario number 2, for example, a newborn هلا حدا مولود صار في عنده profound or severe hypocalcemic seizure, which are يعني difficult to correct. And you're giving calcium supplementation, but they are still actively seizing. So severe hypocalcemia and severe hypocalcemic seizure should make you think about an underlying immune disorder اللي Dye-George syndrome. لأنه من المانيفستيشنز زي ما حكينا either parathyroid aplasia or hypoplastic parathyroid, which lead to severe profound hypocalcemia and hypocalcemic seizure. Or they have abnormal facial features, عندهم developmental delay, intellectual disabilities, so they get evaluated for something else. As part of the evaluation, we found out إنه عندهم high risk ممكن يكون عندهم Dye-George syndrome. Then we refer to an immunologist for follow-up, okay? طيب حكينا إذا عندهم T cell problem، شو يعني T cell problem؟ شو أهمية ال T cells؟ غير هيك؟ اوكي شو كمان؟ هلا T cell excellent اللي هو intracellular viral infections الانتيروفيروس صح زي شو؟ بوليو، كوكساكي. Is it intracellular بس هلا؟ Is it intracellular؟ So the main intracellular, معنى intracellular يعني they exclusively proliferate inside the cell. يعني they can't proliferate outside the cells. طيب هلا if they only proliferate inside the cell, how would an antibody opsonize them? Can antibodies penetrate inside the cell? No. يعني إذا الفيروس escaped intracellularly, they escaped one of the main immune mechanisms in antibody opsonization. But here comes the function of which cell? A T cell, cytotoxic T cell أو CD8, excellent. To engulf and kill السيل واللي فيها، يعني هي بتقتل السيل نفسها الانفكتد والفيروس اللي فيها inhibiting its growth and replication. صح؟ Okay. معناته people with T cell deficiency, they will have problems with enteroviruses. They will have chronic. So if they get any viral illness, even if it's mild, it will turn into a chronic debilitating viral infection. Okay, زي chronic CMV زي ما حكينا. chronic rotavirus ما عم بحكي بس على الانتيروفيروسز. الviral infections in general and in specifically enteroviruses. Okay. طيب. Interleukin 12 receptor deficiency. Okay. حدا بيعرف أي شيء عنه؟ طيب. هلا إحنا part of our immune system مش بس immune cells. تمام؟ There should be inflammatory mediators و cytokines. تمام؟ One of the very important cytokines in our body, interleukin 12. Okay? In order to function, interleukin 12 needs to bind its receptor with beta 1, I think, beta 1 and beta 2 subunits. So it has two subunits, beta 1 and beta 2. So IL-12 without its receptor, it has no proper functioning. Okay. هلا genetic mutation of IL-12 autosomal recessive disorder will lead to inability or deficiency بالinterleukin 12 beta 1 block of the receptor. تمام؟ هلا الانتراكشن between الانترلوكين 12 و its receptor is very important to stimulate, proliferate T helper 1 cells and natural killer cells. Okay? Once they're stimulated عن طريق IL-12 اللي هم natural killers with T helper 1 cells, the end product of this immune reaction with immune stimulation is the production of interferon gamma. Interferon gamma, one of the key ways to fight off mycobacterial infection, زي mycobacterial tuberculosis, for example. Okay. The first hint إنه someone has an underlying IL-12 receptor deficiency appears after receiving the BCG vaccine. Okay. BCG vaccine هو live attenuated. It's mycobacterium. يعني إذا أنت مكان الفاكسين أخذت عينة وفحصتها, it will show acid fast bacillus. Okay, لأنه it's a microorganism, live microorganism injected at the deltoid muscle. Without interferon gamma, we can't contain the mycobacterium. It will replicate. It will cause what we call besigosis or diffuse immune reaction to the BCG vaccine. Besigosis بيكون في عندهم generalized lymphadenopathy, lymph nodes, axillary lymph nodes, and distal lymphadenopathy, distal enlargement, particular endothelial system, hepatosplenomegaly. They will be very sick, febrile, etc. So this would be the first hint to guide you think about IL-12 receptor deficiency. Hyper IgE or CHOPS syndrome. Again, أنا حكينا إحنا أي immune disorder, any underlying primary immune deficiency, it has an underlying genetic mutation. So in the case of CHOPS syndrome, في عنا what we call STAT3, loss of function mutation, وفي other non-mutation mutations بال T helper 17 recruitment أو T helper 17 development. تمام؟ هلا with the absence of STAT3, إذا عندنا STAT3 mutation, رح يكون في عندنا abnormal stimulation و proliferation of T helper 17. تمام؟ Now, because of this, رح يصير في عنا shifting احنا عنا هلا T helper 1 T helper 2 تمام. T helper 1 is usually associated مع production of interferon gamma مع tissue necrosis factor etc. هلا T helper 2 it's responsible to stimulate the B cells تمام, to produce more antibodies and to cause what we call class switching. يعني بتخلي ال B cells to produce more antibodies of specific type اللي هو ال IgE by producing اللي هم interleukin 4 and interleukin 13 تمام. So we need T helper cell 17 with the absence of T helper 17 proliferation رح يصير في switching لا T helper 2 رح يصير, يعني احنا في عنا ميزان بين T helper 1 و T helper 2 تمام. الكفة رح ترجح ل T helper 2 رح يصير في exaggerated stimulation ل T helper 2. ال end result more production of cytokines زي interleukin 4, interleukin 5, interleukin 13 تمام. interleukin 4, interleukin 13 معناته more plasma proliferation, more production of IgE. interleukin 5 معناته more eosinophil stimulation. صار لنا more susceptibility to develop what? allergies or atopies صح؟ عندنا hyper IgE, more IgEs و more eosinophilia تمام. For more eczema, more reactive airway disease or asthma, more شو كمان food allergies صح؟ تمام. So this is the problem with the main problem with hyper IgE or job syndrome. In literature they say they have susceptibility for bone fractures. ليش ما بيعرفوا بس بيلاقوا عندهم انه abnormal bone remodeling. Okay? Abnormal bone remodeling will cause fragile bones and increase the risk of fractures. Chronic mucocutaneous candidiasis type. It's considered one of T-cell disorders, chronic mucocutaneous candidiasis. تمام? Either the defect in the production or genetic defect means ما في production of interleukin 17 or its receptor. تمام? genetic mutations لحد هلا في عنا STAT1 loss of function mutation, في عنا ال AIRE mutation, وفي عنا interleukin 17 receptor alpha gene mutation. تمام. هلا ال most common of them اللي هي ال IL-17 receptor alpha genetic mutation. طيب هلا the problem with this ما نتيجة الديفيشنسي أو الجينيتك ميوتيشن بالIL-17 receptor the alpha receptor of IL-17 رح يصير في عنا reduced interleukin 17 and interleukin 22. هلا interleukin 17 and interleukin 22 they play a major role بنيوتروفيل recruitment to the site of infection. معناته إذا عندنا مشكلة we're unable to recruit neutrophils to the site of infection and we're unable to stimulate neutrophil proliferation as well. This will lead to recurrent mucosal infection by specifically fungal or candida. So this will lead to chronic mucocutaneous candidiasis. So candidal infection that's very difficult to clear out or treat. Okay. combined B and T cell disorder. حكينا عن type من combined T cell و B cell disorder. شو هو؟ common variable. قلنا there is some degree of as well T cell dysfunction فيه. The more severe form من combined deficiency هي severe combined immune deficiency أو SCID. It's one of the lethal primary immune deficiency disorders that has to be picked up very quickly and it has to be treated vigorously and very quickly. Because of how the high morbidity and fatality rate بدول زي أوروبا, they do have screening programs. Part of the neonatal screen or newborn screen مش بياخدوا heel prick test بيحطوها على go30 paper. They check for metabolic disorder, they check for thyroid disorders, for G6PD صح عنا بالأردن شو كمان؟ شو metabolic disorders؟ phenylketonuria, tyrosinemia, excellent. هلا in total we don't screen for SCID unfortunately. هلا why do we need to screen؟ دائما لما يدخلوا أي new screening test على screening program they weigh the benefit versus risk والcost versus the benefit. صح؟ إنه it's very costly to screen all kids for severe complement deficiency, but because the outcome is significantly different between those who got early diagnosed by a screening program and those their diagnosis was delayed لأنه we waited until profound feature of an underlying immunodeficiency appeared. تمام? So if you do bone marrow transplantation for someone with severe complement immune deficiency in the first 6 months of life, 6 months, the cure rate is up to 80%. تخيلوا يعني out of 100 80% will go back to being normal beings. تمام؟ ما بيحتاجوا hospital admissions, ما بيحتاجوا antibody infusion, they're totally fine. However, in countries like Jordan, where we don't have screening program for SCID, we suspected when infants present to an immunologist very late with severe or ugly dermatitis like rash, chronic diarrhea, failure to thrive, chronic viral infections, pneumonia, life-threatening infections, تمام? And then at this point, there's significant delay in diagnosis, وبالتالي the treatment will be affected for 2 reasons. Number one, لأنه in order to cure SCID, you have to do bone marrow transplant or stem cell transplantation. Stem cell transplantation is a very rough procedure. It's itself increases some morbidities لأنه إحنا عم نعطي immune suppressive treatment قبل الترانسبلانت. We suppress their immunity. تمام؟ It's a very risky procedure. In order to do it, the patient has to be in their best shape. يعني they should be healthy, lung تاعتهم okay, ما عندهم lung injury, their weight is excellent, and this is not the case. So most kids in Jordan, when they're diagnosed, they're miserable. They have failure to thrive, chronic infections, their lungs are not okay. So to go through transplant is higher risk than it's if the patient is in a good shape. تمام؟ فعشان هيك المورتاليتي عندنا rate للسكيد is very high because of the delay in diagnosis. تمام. We diagnose through what we call trick count. شو يعني trick count؟ اللي هي T cell receptor excisional circles. شو يعني؟ هلا T cells where are they produced? Produced bone marrow. Then what needs to happen? Where? In the thymus. So they need to circulate and go all through the thymic gland. تمام؟ هلا in this journey طريقهم من البون مارو للثايميك they leave a trace behind them اللي هي زي fragments of DNA. تمام؟ هدول التريسز أو الفراجمنت بنسميهم T cell receptor excisional circles, and while the T cell is maturating they're forming their own receptors. In this process they leave some fragments اللي هي من الريسبتور excisional circles. هدول they can be tested for. يعني احنا بناخذ blood sample نفحص قديش تريك احنا شايفين. Okay? Any patient with a trick count less than 30 they have a higher chance انه عندهم an underlying immune deficiency or T cell problem. So they have to be referred to an immunologist نعملهم thorough immune workup وبالتالي diagnose them with a SCID and to do genetic study for them. تمام؟ فالSCID program is very important. In the UK, for example, I was part of the national screening program. لما كنت هناك بال2022 بلشت pilot study. يعني ما كان عندهم داخل screening program yet. فبدهم يدرسوا جدوى إنه is it worth it ندخل screening test على أول program. فبلشوا شيء اسمه pilot study. أخذوا centers, major centers in the UK فيها يعني sophisticated immune centers, London, Manchester for example, North ناسا صراحة إيش اسم السنتر. وبهدول المراكز صاروا يعملوا screening للنيوبورنز بس بمين مش بكل مستشفيات بس بالمين centers اللي فيها immunologist أو immunology center. And they started to refer anyone with a trick count less than 30 to an immunologist for a thorough evaluation. Out of we saw in our clinic hundreds of cases. Out of them, 3 came back positive for SCID. يعني they had SCID. The 3 of them got transplanted around the age of 3 months of life. The 3 of them is now healthy individuals and they're totally okay. After this pilot study, the conclusion كان إنه yes, by including the screening program to our national program, we are significantly decreasing the morbidity والmortality. البيشنت بتشخصوا بسكيد ليت هم راح يكلفوا الكونتري much more than the screening program لأنهم راح يجوا ب recurrent morbidities, recurrent hospitalizations, recurrent admissions, ICU admissions تمام. ف they weigh the benefit versus cost, and now it's included. Now the UK has the screening program for SCID included in their screening program. Those with SCID زي ما حكينا لأن عندهم problem with both T cells or B cells. They have a problem with fighting off enteroviruses, viral infections in general, parasitic fungal infection. They will present with chronic viral infection, chronic rotavirus, chronic CMV, failure to thrive, chronic diarrhea, ugly dermatitis. الدرماتايتس بتصير في عندهم زي bad eczema. It looks like bad eczema. سببها إنه عندهم dysregulated T cells. The T cells will start attacking their own skin. Okay, فبيجوا ب ugly dermatitis rash. It's a T cell mediated inflammatory process. They will also have low immunoglobulin levels, وبالتالي they're unable to fight off or opsonize bacteria, specifically encapsulated bacteria زي strep pneumo والhemophilus والneisseria. It's contraindicated to give them any live attenuated vaccine. نعرف ليش صح؟ Okay. And the treatment, the cure is bone marrow or stem cell transplantation. Next disorder is ataxia telangiectasia. Remember the 5 A's. The problem is in the ATM gene. This is the first A. People with ataxia telangiectasia, they will have selective IgA deficiency as a result of recurrent sinopulmonary infections and GI infections. They will also have spider angioma as the 3rd A. They will have increased alpha-fetoprotein, the 4th A. And 5th A اللي هي cerebellar ataxia or cerebellar defect. They will have progressive neurodegeneration. تمام؟ If you do immune workup راح تلاقي إنه significant decrease بال IgA and IgE can also be affected, but the main immunoglobulin to be affected is the IgA. They're at risk to develop malignancies like leukemias as well. Okay, hyper IgM syndrome. هلا احنا حكينا part من الفانكشن تاع البي cell is to differentiate into plasma cells. B cell problem is to differentiate mature into plasma cells or antibody producing cells. تمام؟ During an acute infection رح يصير في quick production of IgG. IgM. So initially, acutely during the infection, you need to have IgM ratio higher than all other immunoglobulin subclasses. تمام؟ هلا with time, as the infection is being dealt with, there has to be what we call class switching. So B cells have to switch now production from IgM into other subclasses. اللي هم IgG, IgA or IgG according to our need. يعني if I'm exposed to a parasitic infection, initially رح يصير في surge بالIgM and then gradually there need to be shifting or class switching to IgE and stimulation for eosinophil production to deal with a parasitic infection. تمام? If I've got like a respiratory illness that needs secretory IgA, I need to switch from IgM into IgA. هلا هذا الclass switching is a very interesting example on how B cells and T cells should communicate through what we call CD40 and CD40 ligand interaction. تمام؟ هلا CD40 و CD40 هو عبارة عن بروتين هو cluster of differentiation، يعني زي ليبل على السيرفيس اوف السيلز. هو بروتين. وين موجود السي دي 40؟ موجود على B cells, macrophages ودendritic cells اللي هم الانتيجين بريزنتنج سيلز. it interact مع CD40 ligand اللي هو الموجود على T helper regulatory cells. اوكي، هذا الانتراكشن راح يخلي التي سيل الهيلبر سيل ريجولاتري انها تعمل ريجوليشن للبي سيل برودكشن اوف الانتي بوديز تو بروموت كلاس سويتشنج. يعني هي التي سيل راح توجه البي سيل تحكي لها بليز ناو enough of IgM, you have to switch into other subtypes of immunoglobulins. هلا هذا الانتراكشن بالهايبر IgM syndrome, which is an X-linked recessive disorder, is not there. معناته there is no efficient class switching. So B cells will keep producing IgM. تمام؟ عشان اسمها hyper IgM syndrome. Okay? Those with hyper IgM لأن ما عندهم IgG to opsonize bacteria, معناته they are liable to develop bacterial infections, specifically encapsulated bacteria. They're also unable to fight off opportunistic infections like pneumocystis, and they will have a problem with viruses like CMV infection as well. Okay? If you do flow cytometry, يكون في عندهم high levels of IgM, low levels of IgG, IgE, and IgA. Okay? Wiskott-Aldrich or Aldrich syndrome. Remember water. So W indicates the name Wiskott-Aldrich. A refers to, so Wiskott-Aldrich, WA. T, patients with Wiskott-Aldrich, they will have thrombocytopenia as part of their hematological manifestations. E, they will have eczema and increased risk of atopies in general, in specific eczema. Or they will have recurrent pyogenic or bacterial infection. So it's an X-linked recessive disorder with the WASP-P gene mutation. There's a problem باللeukocyte والplatelet recognition للactin cytoskeleton, which lead to abnormal or defective antigen presentation. Okay? People with Wiskott-Aldrich will have increased susceptibility to autoimmune disorders and some malignancies as well. On blood film, they will have smaller and fewer platelets, so count and shape. Low platelet count, and they will be small in size. Phagocytic dysfunction. Okay. First example, the most common هي leukocyte adhesion defect, which is an autosomal recessive disorder. Those with leukocyte adhesion defect, they have a defect in one of the integrin proteins, or CD18, which is important in the function of phagocytes, which lead to impaired chemotaxis or attraction of phagocytes into the locations where they're needed. Okay, this will lead to recurrent skin and mucosal infections. This will lead to chronic and recurrent pyogenic infections. They will have a problem with deep abscesses or organ abscesses. One of the early manifestations would be impaired or delayed umbilical cord separation. ليش بصير عندهم؟ عمركم شفتوا الكورد تاع النيوبورن كيف بيكون شكله when it starts to separate؟ ما عمره حدا سألكم من العيلة ليش حواليه أحمر أو ليش في discharge؟ So a key mechanism for cord separation is to generate an inflammatory process locally at the site of the cord where it's attached to the skin. This inflammation has to include chemotaxis and attraction of phagocytes like neutrophils, okay, to potentiate the inflammatory process. من البرودكتس الانت برودكت للنيوتروفيل، حكينا شو وظيفة النيوتروفيل؟ هي عبارة عن ماكروفيج، تمام؟ killing of microorganism. هلا when neutrophils are attracted to where they're needed, the end product is to form pus or pus formation, تمام؟ Pus formation, this indicates good immune response, تمام؟ فusually لما الأهل يجوا يسألونا ليش في pus and redness around the umbilical cord stump، this is normal, this is part of a normal immune inflammatory reaction locally at the site of the stomach. Patients with phagocytic dysfunction like LAD, they will have a problem زي ما حكينا ب one of the integrins اللي هو CD18, so they will have defective attraction of the phagocytic cells خاصة النيوتروفيلز، وبالتالي هاي الانفلاماتوري بروسيس ما راح تكمل صح؟ and we need neutrophils. وبالتالي there will be delayed cord separation or separation of the umbilical cord. Usually most patients or most healthy newborns, the umbilical cord separates within the first 2 weeks, and we don't consider it delayed unless it's beyond 4 weeks of age, okay? Chidiac Higashi. Chidiac Higashi is one of the lysosomal, it's a problem with lysosomal fusion inside neutrophils and other phagocytes. It's an autosomal recessive disorder. زي ما حكينا مشكلة بالمايكروتيوب dysfunction, end result phagosome lysosome fusion problem. احنا we need الphagosome والlysosome to interact عشان يصير في عنا ايش؟ lysis للمايكرو اورجانيزم اللي جوا الphagosome صح؟ Okay. So they will have recurrent pyogenic infection. Bacteria will not be engulfed and killed as is expected with phagocytes. صح؟ لأن عندهم مشكلة بالphagocyte lysosome infusion. وبالتالي they are liable to develop recurrent chronic pyogenic infection زي ما حكينا, strep pneumo and other pyogenic infections. They also have extra immune manifestations. They might have lymphohistiocytosis, which is a hematological problem that can cause problem if it invades to other organs. Pancytopenias, they might have coagulation defects. They will also have peripheral neuropathy, usually it's progressive and degenerative. They might also present with partial albinism, okay? Treatment طبعا bone marrow transplantation. CGD or chronic granulomatous disease. شو يعني granulomatous disease? Excellent. Granuloma formation. أعطيني example of granuloma formation. Tuberculosis. So بصير في عندنا the production of. ليش بصير production of granulomas? So this is part of our immune reaction, صح? To kill the pathogen. But unfortunately in the process بصير في lung damage, صح? طيب. CGD, it's an X-linked disease where there's a defect in the NADPH oxidase, تمام؟ هذا الباثواي أو الأوكسيديز deficiency, the end result تاعيته that our body is unable to produce a superoxide, تمام؟ Superoxides هم products needed to kill البكتيريا، تمام؟ نسميه هذا reaction respiratory burst، okay؟ طيب، هذا respiratory burst هو reaction بيصير inside the neutrophils to kill البكتيريا زي ما حكينا، وإذا في defect بال NADPH oxidase this process will not happen. وبالتالي increase susceptibility to microorganisms that we need the respiratory burst to kill. شو هم هدول microorganisms specific بنسميهم احنا الكاتاليز positive microorganisms، اوكي؟ شو في عندنا example لكاتاليز positive microorganism؟ كانديدا ولا aspergillus؟ اوكي شو كمان؟ نوركارديا. شو كمان؟ سودوموناس ايريجينوزا، الستيريا مونوسيتوجينز، صح؟ ايكولاي، ستاف، سيرينشا ماركيسنس، دول كلهم catalase positive. So we need هذا respiratory burst produced by neutrophils to kill and contain catalase positive infections. In the absence of NADPH oxidase ما في رح يكون عندنا healthy respiratory burst reaction to neutrophils, وبالتالي we're not only liable to develop recurrent infection عن طريق catalase positive microorganism, but we're also unable to get rid of them, or فرح يصير في عنا chronic infections as well with increased morbidity and increased mortality rate, okay? The diagnosis through what we call a neutrophil function test. زمان كنا نعمل nitroglutatrazolium, هلا it's been replaced مع ال DHR test. Okay, it's more sensitive and more specific. The treatment for CGD is stem cell transplantation or bone marrow transplantation. In the meanwhile, while we're preparing the patient to be transplanted, they have to be on prophylactic antibiotic to prevent زي ما حكينا infections through the catarrhs positive microorganisms. يعطيكم العافية.